Usually, when we think about a medical prescription, right, there's this expectation of just absolute uniform precision. It feels, I don't know, it feels like engineering.
Right, yeah, like it's mass-produced.
Exactly. You need an antibiotic, so the doctor prescribes exactly 500 milligrams of amoxicillin, and that little capsule is a chemically identical clone to the millions of others rolling off the assembly line.
Yes.
And it's comforting, you know? It's completely binary. It either is the drug or it isn't.
Right, because the pharmaceutical supply chain completely relies on that level of standard deviation. I mean, a chemical compound is a chemical compound, regardless of where it was synthesized.
But then you step into the world of transfusion medicine, and suddenly that comforting assembly line just vanishes. We aren't dispensing chemicals anymore. We are literally transplanting living, biologically active human tissue.
It's a completely different paradigm.
Yeah, and the landscape goes from perfectly uniform to this landscape of immense biological variability. You are dealing with a living, breathing product that comes with its own immune system, its own history, its own metabolic waste, and crucially, its own expiration clock.
And honestly, that biological variability is exactly what makes the blood bank the most intimidating bench in the laboratory for a lot of people.
Oh, absolutely. It really is.
It is the absolute definition of diagnostic muddy waters. When you have a trauma patient bleeding out and their antibody screen suddenly rings positive, you can't just look up a generic answer in a manual.
Right, you can't just flip to page 42 and find the solution.
Exactly. You have to synthesize the immunology, the chemistry, and the clinical picture all at the exact same time.
Which is exactly why we're tailoring this deep dive specifically for you, the dedicated medical laboratory scientist student. We know you are currently grinding away, preparing to conquer the ASCP blood bank and immunohematology exam.
And it is a tough exam.
It really is. You already have the flashcards. You already read the textbooks. So our mission today isn't to just, recite a list of facts back to you. We are going to take the study material you provided and break it down into first principles understanding.
Because if we can trace the biological why behind these concepts, from the donor's arm all the way to the transfusion bench, the exam stops being a memorization test.
Yeah.
It becomes an exercise in applied logic. The exam writers for the ASCP are entirely focused on safe, independent practice.
Right. They want to know if they can trust you alone in the lab at 2 a.m.
Exactly. They are going to test your critical thinking by exploiting the nuances of human biology. They want to see if you understand the downstream consequences of every single decision you make on that bench.
So to build that logic, we have to start at the absolute origin point of the blood supply, which is the donor's arm. Before a single unit of blood can be processed, we have to ensure it is actually safe to collect. And the donor screening process is the very first layer of safety. We have two competing priorities here, right? We have to protect the recipient from the donor's blood, obviously, but we also have to protect the donor from the physiological stress of the donation itself.
Right, and the baseline metrics for donor eligibility are heavily tested precisely because they have to balance those two priorities perfectly.
So the study guides often use a mnemonic character to visualize this baseline, Danny Donor. Let's build Danny's vital stats and really explore the physiological mechanisms driving these hard cutoffs. Let's start with age.
Okay.
The baseline is 17 years old. But what stands out to me immediately is that there is no maximum age limit. Like a 78-year-old can walk in and donate provided the medical director evaluates and clears them. That seems wild to me.
Well, chronological age is far less important than physiological age in transfusion medicine. We're really looking at cardiovascular reserve.
Okay, meaning how their heart handles stress.
Precisely. Losing a unit of blood is a sudden, significant volume drop. As long as an older individual has the cardiovascular elasticity and the bone marrow capacity to regenerate that volume without going into ischemia, their age itself is not a disqualifying factor.
That makes sense. Now, temperature, on the other hand, is a rigidly strict cutoff. The oral temperature must be less than or equal to 37.5 degrees Celsius, which is 99.5 degrees Fahrenheit.
Yes, very strict.
And see, in a clinical hospital setting, 99.6 barely even registers as a low-grade fever. A doctor might not even give you Tylenol for that. So why is the blood bank so incredibly uncompromising about a fraction of a degree?
Because of the incubation environment we're about to put that blood into, we aren't primarily worried that the donor has the flu or a cold. We are worried about transient bacteremia.
Transient bacteremia. Break that down for me.
Sure. Think about when you brush your teeth vigorously or, chew on hard food like tortilla chips. You actually create microscopic tears in your gums.
Oh, wow. Okay.
And normal flora from your mouth, like Staphylococcus or Streptococcus species, momentarily enter your bloodstream through those tears.
But in a healthy donor, the immune system's macrophages just sweep that up in a few minutes, right? Like, it's not a big deal.
Exactly right. The donor will never even know it happened. But that tiny immune battle might cause a very transient spike in their core temperature, say, to exactly 99.6 degrees Fahrenheit.
Oh, okay. I see where this is going.
Right. If we draw their blood at that exact moment, we are collecting a few of those live bacteria. And once that blood is in a bag, it is completely severed from the donor's immune system.
So there are no macrophages left to fight it off.
None. And if that bag happens to be platelets, which we store at room temperature, those 3 little bacteria will undergo rapid logarithmic growth.
Oh, man. So it just becomes a bacterial soup?
Yes. Within 5 days, that bag is teeming with billions of bacteria and their endotoxins. Transfusing that into a patient causes immediate, overwhelming, and often fatal septic shock. So 37.5 degrees Celsius is our line in the sand to detect that microscopic transient bacteremia.
Wow. Okay, so you aren't just measuring a fever, you are literally trying to intercept an incubator. That completely reframes the rule.
It does. It's all about what happens outside the body.
Okay, moving to the cardiovascular vital signs. The pulse must be between 50 and 100 beats per minute, and the blood pressure has this great mnemonic in the study material. Sky over dirt.
Yes, a classic memory aid.
So the systolic, the top number, the sky must be less than or equal to 180. The diastolic, the bottom number, the dirt, must be less than or equal to 100. So 180 over 100.
And this is entirely about the baroreceptor reflex and protecting the donor. When we draw 450 milliliters of whole blood, we are removing roughly 10% of an adult's total blood volume in about 10 minutes.
Which is pretty fast for that much fluid.
It is. The donor's body compensates by triggering a sympathetic nervous system response. The heart rate increases, and the peripheral blood vessels constrict to maintain blood pressure to the brain.
Okay, so if a donor walks in already highly hypertensive, like with a systolic way over 180,
Their vessels are already under immense strain. Triggering that acute volume loss could push their cardiovascular system into a hypertensive crisis or trigger a major cardiac event right there in the chair.
so we're just avoiding a heart attack in the donor center, basically.
Precisely.
Now, that volume loss calculation ties directly into the weight requirement, right? The floor is 110 pounds or 50 kilograms. I always assumed this was just, a general proxy for body size. But it is actually a strict mathematical ratio based on the physical blood bag itself.
Right. The standard collection bag is manufactured with very specific volume of liquid chemical anticoagulant, usually 63 milliliters, which is designed to mix perfectly with 450 milliliters of human blood. A human being has roughly 70 to 75 milliliters of blood per kilogram of body weight. So a 110-pound person has just enough total blood volume that losing 450 milliliters won't throw them into hypovolemic shock.
And it provides exactly enough volume to prevent the anticoagulant in the bag from becoming toxic.
Exactly. The math has to balance.
We are definitely going to explore the math of what happens when a donor doesn't meet that weight limit a bit later, because I know that's a huge topic.
Oh, absolutely. ASCP loves that math.
But first, the final baseline metrics are the hematology cutoffs. For an allogeneic whole blood donation, meaning donating for the general public supply, the hemoglobin must be at least 12.5 grams per deciliter, and the hematocrit must be at least 38%.
This is an area where the exam writers will absolutely test your attention to detail, because those thresholds change depending on the type of donation.
Right.
For an allogeneic donor, we are requiring a hemoglobin level that is actually slightly higher than the lower limit of normal for some demographics,
Right.
particularly menstruating women.
Wait, really? So we're requiring them to be more than just normal?
Yes, we are building in a safety margin. We know the donation is going to drop their hemoglobin by about 1 gram per deciliter. We cannot ethically push a healthy donor into an anemic state just to harvest their blood.
Ah, okay. So Danny Donor clears all his vital signs. He's mathematically and physiologically capable of safely losing 450 milliliters. Now we have to look at his history, which brings us to the deferral periods.
And deferrals, again, aren't arbitrary punishments. They are biological incubation periods.
Right. Let's trace the logic of these timelines, starting with the short-term deferrals. Aspirin use is a 2-day or 48-hour deferral. But the criteria specify this is only if the donor is the sole source of platelets for a patient.
That sole source part is critical.
Right, but looking at the pharmacology, I see a huge conflict here. Aspirin irreversibly acetylates the COX-1 enzyme in platelets. It permanently destroys their ability to synthesize thromboxane A2, which they need to aggregate and form a clot.
Yes, it permanently poisons them.
And platelets live for about 7 to 10 days in circulation. So if the circulating platelets are permanently poisoned for over a week, how does a 48-hour deferral make any sense at all?
That is a fundamental pharmacological contradiction that trips up a lot of students. You are entirely correct about the circulating platelets. The ones exposed to the aspirin are permanently deactivated. They're completely useless for clotting.
So why don't we defer them for 10 days?
Because we aren't waiting for those poisoned platelets to somehow heal. We're waiting for the bone marrow to replace them.
Oh.
Right. Deep in the bone marrow, massive cells called megakaryocytes are constantly fragmenting their cytoplasm to produce brand new platelets. It takes roughly 48 hours for those megakaryocytes to pump out enough fresh, unexposed platelets into the bloodstream to constitute a therapeutically viable dose.
So we are just waiting for the factory to ship a new batch that hasn't been exposed to the drug. That is so cool.
Yes, and that caveat, only if the donor is the sole source. That refers to apheresis collection,
Right.
where one donor provides an entire massive dose of platelets for one single patient.
But if we are collecting whole blood and just pooling those platelets with 5 other random healthy donors.
Exactly. The functional platelets from the other 5 people will completely compensate for the aspirin deactivated ones from that one donor.
You really have to trace the blood product all the way to the transfusion environment to understand the deferral.
You do. It's all connected.
Let's look at vaccines, which carry a 2-week or 4-week deferral. It's 2 weeks for live attenuated vaccines like measles, mumps, polio, and yellow fever. But it stretches to 4 weeks for rubella and varicella.
Right.
But if someone gets a flu shot, which is usually a killed or recombinant vaccine, there's no deferral at all. Why the difference?
The mechanism here is viremia. When you receive a live attenuated vaccine, you are being injected with a weakened but fully intact and actively replicating virus.
Okay.
The goal is to establish a mild infection so your immune system can mount a robust response. So for the next 2 to 4 weeks, depending on the specific replication cycle of that viral strain, there are live viral particles freely circulating in your plasma.
Oh, I see. So if we collect your blood during that window
and transfuse it into a patient undergoing heavy chemotherapy whose immune system is completely wiped out, that weakened vaccine strain is no longer weak to them. Without an immune system to keep it in check, it will replicate wildly and could cause a fatal systemic infection.
That makes perfect sense. Okay, next on the timeline is a 6-week deferral for pregnancy.
Yes. Pregnancy dramatically alters maternal hemodynamics. A pregnant woman's plasma volume expands by almost 50% to support fetal circulation.
50%? That's a massive fluid shift.
It is. And her iron stores are heavily depleted to build the fetal red blood cells. After delivery, it takes the maternal bone marrow roughly 6 weeks of continuous erythropoiesis to replace those lost red cells, and for her fluid volumes to return to a baseline state where she can safely tolerate a massive fluid loss, like a donation.
So it's strictly a recovery period for her own safety. And rounding out the short term is the 8-week or 56-day deferral after a standard whole blood donation. Now, we can replace the lost liquid plasma volume in about 24 to 48 hours just by drinking water, right?
Yes, the liquid volume comes back very fast.
But the actual cellular mass takes much longer.
It is entirely an iron kinetics issue.
Yeah.
You lose roughly 200 to 250 milligrams of iron with every single whole blood donation.
Yeah.
Your body has to mobilize ferritin from tissue stores, transport it to the bone marrow, and synthesize brand new hemoglobin.
And that takes a full 2 months.
8 weeks is the physiological minimum required to rebuild that red cell mass to a level where a second donation won't plunge you straight into iron deficiency anemia.
Okay, moving into the medium-term deferrals, we hit the 12-month category. And this list includes a history of syphilis or gonorrhea post-treatment, receiving a blood transfusion, mucous membrane exposure to blood, accidental needle sticks, sexual contact with someone at high risk for HIV or hepatitis, and incarceration in a correctional facility for more than 72 hours. The central theme here is undeniable. It's high-risk exposure to bloodborne pathogens.
This 12-month period is the classic viral window period, deferral. And it is a concept you must understand deeply for the exam.
Break it down for us.
When a virus like hepatitis C or HIV enters the body, it doesn't instantly trigger a massive immune response. The virus has to bind to target cells, penetrate the membrane, hijack the cellular machinery, and actually begin replicating.
Which takes time.
Exactly. Furthermore, it takes even more time for the host's immune system to recognize that massive viral load and begin synthesizing detectable levels of antibodies. That lag time between the exact moment of infection and the moment our laboratory test can actually detect the infection, that is the window period.
So even with the most advanced testing we have, we still have a blind spot.
Yes, we do. A 12-month deferral covers the maximum possible biological incubation and window period for these major pathogens. If you suffer a needle stick injury in a hospital and you test negative for HIV and hepatitis an entire year later, the statistical probability that you harbor those viruses is effectively zero.
Now, you mentioned receiving a blood transfusion is also on that 12-month deferral list. I think this is a huge counterintuitive trap.
It is. Students get confused by it all the time.
Because you go to a hospital, you receive blood that has been rigorously tested and deemed perfectly safe by the blood bank, yet the very act of receiving that safe blood gets you banned from donating for a year. That sounds so contradictory.
It seems contradictory until you view it through the lens of absolute risk mitigation. The blood supply is incredibly safe, yes, but it is not a zero-risk product.
Right.
Every transfusion is a massive liquid tissue transplant from an anonymous donor. The 12-month deferral is essentially a conservative firewall. We are assuming that there is always a minuscule chance the blood you received contained a novel pathogen or a virus that slipped through the window, period.
Oh, I see. By deferring you for a year, we ensure that if you did acquire something via that transfusion.
It does not get amplified and cycled back into the donor pool. We break the chain.
Wow. Okay, stepping up the timeline again, we find a highly specific 3-year deferral. This applies exclusively to malaria.
Right.
If you are an immigrant or a visitor from a malaria endemic country, or if you were personally diagnosed with malaria, you cannot donate for 3 years. Why is malaria treated so differently than HIV or hepatitis? Why does it get a massive 36-month window?
Because of the unique biological life cycle of the Plasmodium parasite. HIV and hepatitis are viruses that circulate freely in the plasma to find their target cells. Malaria is caused by a protozoan parasite that is fundamentally intracellular.
Intracellular, so it goes inside the cells.
Exactly. When an infected mosquito bites you, it injects sporozoites that travel directly to your liver, and they can stay dormant in the liver as hypnozoites for extended periods. When they finally emerge, they burrow directly inside your circulating red blood cells to replicate.
So they are physically hiding inside the red blood cell membrane.
Yes. Because they are inside the cell, our standard immune responses are somewhat evaded, and more importantly for us, standard blood bank leukocyte reduction filters cannot catch it. A filtered unit of red blood cells is just as infectious. The 3-year mark without clinical symptoms is the generally accepted epidemiological threshold, where the parasite is considered fully cleared from all host tissues.
It's literally hiding inside the exact product we are trying to harvest. That is terrifying.
Biology is clever.
That brings us to the final category, the permanent deferrals. These are the life sentences. History of viral hepatitis after your 11th birthday. A confirmed positive hepatitis B surface antigen, repeatedly reactive anti-HBC or HTLV tests. Any history of HIV or hepatitis C. A history of babesiosis or Chagas disease. And receiving human pituitary growth hormone or a duramater transplant.
Yes, quite a list.
Let's dissect the first one because it is a classic exam trap. Viral hepatitis after your 11th birthday. The exam raters will give you a scenario about a 25-year-old donor who had jaundice and hepatitis when they were 9 years old.
Right, and the biological logic here hinges entirely on the epidemiology of different hepatitis strains.
Walk us through it.
If a child under the age of 11 contracts hepatitis, statistically, it is overwhelmingly hepatitis A. Hepatitis A is transmitted via the fecal-oral root. Think children not washing their hands on a playground.
Typical kid stuff.
Exactly. It causes an acute infection, the child gets sick, and then the immune system clears the virus entirely. The virus is completely eradicated from their body, leaving behind only protective antibodies. They do not become chronic carriers, therefore they are perfectly safe to donate blood later in life.
But the moment you cross that 11th birthday, the statistical assumption flips entirely, right?
It does. After age 11, the likelihood that the infection was caused by hepatitis B or hepatitis C skyrockets. These strains are transmitted via blood and sexual contact. And crucially, they frequently evade complete immune clearance, establishing a lifelong chronic carrier state in the liver.
So the virus can just hide out in the liver for decades.
Yes. It can integrate into the host or maintain a low-level replication that constantly seeds the bloodstream. The blood bank is not going to take the risk of trying to track down a 20-year-old pediatric medical record to prove which strain you had.
Yeah, that would be impossible.
So the rule is, if you had hepatitis after age 11, you are assumed to be a chronic carrier of B or C, and you are permanently deferred to protect the supply.
I want to look at those last two bizarre ones, human pituitary growth hormone and dura mater transplants. The material notes these are permanent deferrals due to the risk of CJD, Creutzfeldt-Jakob disease.
Yes. Prion diseases are a nightmare scenario for transfusion medicine.
Remind me what a prion is exactly. It's not a virus, right?
Right. Prions are not viruses. They are not bacteria. They don't have DNA or RNA. They are simply normal human proteins that have misfolded into a pathological shape.
That sounds bizarre. A misfolded protein can be infectious.
It can. When this misfolded protein bumps into a normal protein in your brain, it forces the normal protein to misfold as well. It creates this cascading chain reaction that slowly turns the brain into a sponge.
Wow.
And what makes prions absolutely terrifying for the blood bank is their indestructibility. You cannot kill them with standard sterilization heat or gamma radiation without completely vaporizing the blood itself.
So how does someone get exposed to prions through growth hormone or dura mater?
Well, historically, before synthetic hormones were widely available, growth hormone was harvested and pooled from human cadaver pituitary glands. Dura mater, which is the connective tissue membrane covering the brain, was also harvested from cadavers for surgical grafts.
Oh, we see where this is going.
Yes. If just one of those cadavers harbored CJD, the prions were transferred to the recipients.
Okay.
Because prions can incubate silently in a human for 30 or 40 years before causing symptoms, and because we have no routine blood test to detect them, anyone who received those specific human-derived cadaver products is permanently banned.
It is an incredible intersection of history, epidemiology, and protein biochemistry. It makes total sense why that's a permanent ban.
Absolutely.
Okay, let's shift our focus to special collections. We've laid out the ironclad rules for an allogeneic donor, a healthy volunteer donating for a stranger. But what happens when the script is flipped and the patient is donating blood for themselves? This is an autologous donation.
Right. And the moment the blood is intended exclusively for the person donating it, the entire philosophy of the blood bank changes completely.
How so?
The primary goal shifts from protect the public blood supply to facilitate this specific patient's surgical care. Because the patient is simply getting their own blood back, the risk of transmitting a new infectious disease or causing an autoimmune reaction drops to near zero.
Consequently, the physiological criteria relax dramatically, don't they?
Very dramatically.
There is absolutely no age limit for an autologous donation.
Yeah.
Like if a pediatric patient needs major orthopedic surgery and has veins large enough to accommodate the needle, they can donate for themselves. The hematology thresholds drop as well. Instead of needing a hemoglobin of 12.5, the autologous donor only needs a hemoglobin of 11.0 grams per deciliter or a hematocrit of 33%. And they can donate up to 72 hours before their scheduled surgery.
The danger here is logistical, not immunological. Because we are collecting blood from patients who might be mildly anemic or who might actually test positive for hepatitis or HIV, this blood is inherently dangerous to anyone except that specific patient.
Right. You definitely don't want that getting mixed up.
No. And therefore, the exam will heavily test your knowledge of the strict segregation rules. Autologous units must be physically separated from the general inventory, often in a dedicated refrigerator space, and boldly labeled for autologous use only.
And what happens if the patient goes through surgery, everything goes perfectly, and they don't actually need the blood? We just have a perfectly good bag of blood sitting in the fridge.
You absolutely must discard it.
Really? You can't just give it to someone else?
No. Crossover, which is the act of taking an unused autologous unit and placing it into the general allogeneic supply, is strictly forbidden in modern practice. The donor criteria were too lax. You cannot guarantee the safety of that unit for a stranger. It goes in the biohazard bin.
Okay, that brings us to a mathematically fascinating scenario that the ASCP exam is famous for, the low-volume autologous calculation.
Get your calculators out for this one.
Yeah, we talked earlier about how the standard blood bag has 63 milliliters of chemical anticoagulant, perfectly calculated to mix with 450 milliliters of whole blood from a 110-pound donor.
Okay.
Let's say our autologous donor is a teenager who only weighs 90 pounds, or roughly 41 kilograms. If we just draw a full bag,
If you just use a standard bag and draw until their blood pressure drops, you're going to create a highly toxic product.
right. I like to think of this using a Kool-Aid analogy. The 63 milliliters of anticoagulant is like a concentrated packet of Kool-Aid powder, and the 450 milliliters of blood is the pitcher of water.
Okay, I like that.
If you only have enough water to fill half a pitcher, you cannot dump the entire packet of powder in. If you do, the chemical concentration becomes incredibly overpowering and toxic. You have to physically dump some of the powder out of the packet before you mix it.
That is exactly what happens with the anticoagulant, specifically the citrate.
Explain the citrate toxicity part.
Sure. Citrate's job is to chelate, or bind to, the free calcium in the blood to stop the coagulation cascade. If the ratio of citrate to blood is too high, there is a massive excess of unbound citrate floating around in the bag.
And when you transfuse that back into the patient,
That excess citrate floods their bloodstream, aggressively binding to their internal calcium. The patient goes into acute hypocalcemia, their muscles spasm into tetany, and their heart can suffer fatal arrhythmias due to QT prolongation. It's incredibly dangerous.
So how do we calculate exactly how much powder to remove? It's a 3-step mathematical process, right?
It is. Walk us through it.
Okay, step 1. We have to figure out how much blood we are biologically allowed to draw from this 90-pound patient. We take their actual weight and divide it by the standard weight of 110 pounds.
Right.
So 90 divided by 110 equals 0.81. This tells us they can safely donate 81% of a normal unit. We multiply that ratio by the standard 450 milliliter draw.
Making sure we protect them from hypovolemia.
Exactly. So 0.81 times 450 equals 368 milliliters. That is our absolute maximum target draw volume for this patient.
Excellent. You protected the donor. Now, step 2, protect the blood from toxicity.
We know the standard ratio of anticoagulant to blood is 14%. If you divide 63 by 450, you get 0.14. So we multiply our new target draw volume, 368 milliliters, by 14%.
Okay.
368 times 0.14 equals 51.5, which rounds up to 52 milliliters. That is the exact volume of anticoagulant we actually need to properly preserve 368 milliliters of blood.
Perfect. And step 3.
Step 3 is the physical adjustment. The bag currently holds 63 milliliters. We only need 52 milliliters. 63 minus 52 equals 11. We must physically extract 11 milliliters of anticoagulant from the bag using a sterile syringe before we ever stick the needle into the patient's arm.
If you can walk through that exact logic on the exam, substituting whatever weight they give you, you will never miss a low-volume collection question. It's always those 3 steps.
Awesome. Let's briefly touch on apheresis before we move into the testing laboratory. Apheresis is just a marvel of fluid dynamics to me.
It really is.
Instead of taking whole blood and separating it later, we hook the donor up to a centrifuge machine right at the chair. Blood flows out of the arm into the centrifuge where it is separated by specific gravity. The machine siphons off one specific component, like the plasma or the platelets, and then it pumps the remaining red blood cells and fluid back into the donor.
And because we are returning the red blood cells, which carry the oxygen, the donor doesn't suffer the same physiological exhaustion.
Right.
This allows us to collect a massive, concentrated therapeutic dose of platelets from a single person,
Yeah.
which is equivalent to what we would get from pooling 6 normal whole blood donations.
That's incredible. The FDA restricts the total volume collected via apheresis to 500 milliliters, or 600 milliliters if the donor is over 175 pounds. And remarkably, if someone donates apheresis platelets, they only have to wait 48 hours before they are eligible to donate whole blood, assuming they meet all other criteria.
Which really highlights how rapidly the liver and bone marrow can regenerate plasma proteins and platelets, right?
Mm-hmm.
Especially compared to the agonizing 8-week wait to rebuild red blood cell mass.
Okay, so the donation is complete. The blood is in the bag. Now we transition into the testing laboratory. This blood cannot go anywhere near a patient until it has run a highly complex gauntlet of molecular and serological testing.
Because the donor questionnaire is the first layer of safety, but it relies on human memory and honesty, which are inherently flawed. People forget things or they lie.
Right.
The testing bench relies on strict molecular biology. It doesn't lie.
Every single unit must be typed for ABO and RH, including a test to detect a weak expression of the D antigen. It undergoes an antibody screen to ensure the donor hasn't developed unexpected antibodies from a prior pregnancy or transfusion that could attack a recipient.
Basic immunohematology.
Then we hit the infectious disease panel, and it is extensive. Serologic tests for syphilis, hepatitis B surface antigen, hepatitis B core antibody, hepatitis C antibody, HIV 1 and 2 antibodies, HTLV 1 and 2 antibodies, West Nile virus RNA, and a screening for Chagas disease.
I'm going to point out the Chagas test specifically because it's unique.
Oh, how so?
Well, Chagas disease is caused by the parasite Trypanosoma cruzi, which is transmitted by the reduvid bug, primarily in Central and South America. The parasite can form tissue cysts in the heart muscle, leading to fatal cardiomyopathy years later.
Yikes.
But the FDA only recommends screening a donor for Chagas disease once in their lifetime.
Wait, just once? Why?
Because the reduvid bug vector is incredibly rare in the United States. If a donor tests negative once, the statistical probability of them actually acquiring Chagas disease domestically before their next donation is considered negligible.
That makes total sense. They aren't going to catch it here.
Exactly.
Now let's look at the cornerstone of modern blood bank safety. NAT, or nucleic acid testing. If we are already running highly sensitive serological assays to detect the antibodies for hepatitis C and HIV, why are we spending millions of dollars to also run NAT testing for the exact same viruses? On the surface, it seems like redundant overkill.
It is only redundant if you assume the immune system responds instantaneously to an infection, which, as we discussed with the window period, it absolutely does not.
Right.
Serological testing, looking for anti-HCV or anti-HIV, is searching for the host's reaction to the virus. When a donor is infected, the virus begins replicating immediately. But it takes time for the immune system's B cells to recognize the viral antigens, undergo clonal expansion, and actually produce enough IgG antibodies to be detectable in a standard laboratory assay.
And during this delay?
During this delay, the window period, the donor's blood is packed with live, highly infectious viral particles, but their antibody test will read perfectly negative.
So NAT bypasses the immune system entirely.
Exactly. NAT utilizes a PCR polymerase chain reaction technology. We take the donor's plasma, extract any genetic material present, and use specific primers and enzymes to exponentially amplify the viral RNA or DNA.
Wow.
We aren't waiting for the donor's body to signal an infection. We are searching for the literal genetic blueprint of the virus itself. Implementing NAT profoundly revolutionized transfusion safety.
Because it shrinks the window.
Radically. By detecting the viral RNA directly, we shrunk the window period for HIV down to roughly 9 days, and for hepatitis C down to an astonishing 7.4 days.
And the downstream effect of that technology is reflected in the current transfusion-associated infection risks. The exam will expect you to know these benchmarks. The risk of contracting HIV from a screened blood transfusion is approximately 1 in 1,467,000. For hepatitis C, it is 1 in 1,149,000.
Those numbers represent a monumental triumph of laboratory science. But, they also underscore a sobering reality. The risk is incredibly low, but it is not zero. Those 9 days and 7.4 days are still blind spots.
Right. If a donor was infected 5 days before they walked into the blood center, the NAT test will be negative and that virus will be transfused.
Exactly.
Before we leave the testing bench, there's a note about conditional testing. We blanket test every unit for HIV and hepatitis, but we only test for CMV cytomegalovirus conditionally.
Yes. And the reason for that is simple. If we discarded every unit of blood that tested positive for previous CMV exposure, the blood supply would instantly collapse.
Is it that common?
Very. Between 50 and 80% of the adult population has been exposed to CMV. It establishes a latent infection inside the white blood cells, specifically the monocytes. For any patient with a functioning immune system, receiving a transfusion of CMV-positive blood is entirely harmless. Their immune system keeps the latent virus locked down.
But if we have a patient whose immune system is non-existent, like a premature neonate whose immune system hasn't developed, or a leukemia patient who just underwent a bone marrow transplant, giving them a load of CMV-infected white blood cells is like throwing a match into dry brush.
A perfect analogy. The virus activates and causes a fatal opportunistic infection. So, for those highly specific, vulnerable populations, we must provide CMV-negative blood.
Or, as is more common in modern practice, we utilize leukocyte reduction, right? By filtering out the white blood cells, we physically remove the virus's hiding place, rendering the blood CMV safe.
Exactly. CMV safe is considered equivalent to CMV negative in most clinical scenarios today.
And that leads perfectly into the chemistry of storage. We have collected the blood safely, and we've proven it is free of detectable disease. Now we face a monumental biochemical challenge. We have nearly half a liter of living human tissue sitting in a plastic bag on a counter, completely severed from its host's lungs, liver, and kidneys. How do we keep these cells from suffocating in their own waste and dying before they reach a patient?
It's an incredible problem. We have to engineer a highly specific life support system inside that plastic bag. We rely on anticoagulant and preservative solutions to manipulate the red blood cell's metabolism.
Let's decipher the chemical alphabet soup that makes this possible. We see combinations like ACD, CPD, and CPDA1. What is the precise biological role of each chemical? Starting with citrate. We touched on this during the autologous math problem.
Right. Citrate is the foundational anticoagulant. The coagulation cascade is a complex series of enzymatic reactions that heavily depend on ionized calcium as a critical cofactor.
So calcium is like the spark plug for the clotting engine.
Essentially, yes.
Yeah.
Citrate acts as a chelating agent. It physically binds to the free calcium in the plasma, locking it away. Without available calcium, the coagulation enzymes are completely paralyzed, and the blood remains fluid in the bag.
Next is phosphate.
The red blood cells are alive. Even in the refrigerator, they are metabolizing. Because they have no mitochondria, they rely strictly on anaerobic glycolysis to generate ATP.
And the byproduct of glycolysis is lactic acid.
Exactly. If that acid builds up in the closed environment of the bag, the pH will plummet, and the acid will literally denature the cellular proteins and destroy the cell membrane. Phosphate acts as a chemical buffer, absorbing the hydrogen ions and preventing the pH from dropping too rapidly.
And then there is dextrose, which is essentially just glucose. It is the fuel source. It provides the sugar required to run that glycolysis pathway so the cell can maintain its sodium-potassium pumps and keep its structural integrity.
Right. If we mix citrate, phosphate, and dextrose, we get CPD. Blood stored in a standard CPD solution has a strict shelf life of 21 days.
But if we add an A to make CPDA1, the shelf life jumps to 35 days. What does adenine do to buy us 2 extra weeks of viability?
Adenine is a direct substrate used by the red cell to synthesize more ATP. With an abundant supply of adenine, the cell can maximize its ATP production, which keeps the membrane pumps running longer and prevents the cell from prematurely lysing. It is a simple nutritional boost with massive logistical implications for the blood bank inventory.
We can even push it further. If we spin the blood down, remove the plasma, and add a specialized additive solution like AS1, AS3, or AS5, which contain even more adenine, dextrose, and sometimes mannitol to stabilize the membrane, we can extend the shelf life to a maximum of 42 days.
42 days is the gold standard for red cells today.
But what happens if a unit hits day 43? Is it destined for the biohazard bin? Surprisingly, there is a biochemical rescue operation available called a rejuvenating solution.
Yes, though it's rare to see it used practically.
But it's on the exam. It contains pyruvate, inosine, phosphate, and adenine. You can add the solution to a unit of blood up to 3 days after it has expired. It forces the cells to synthesize massive amounts of ATP and 2,3-DPG, essentially resurrecting them from the brink of cellular death.
It is biochemically brilliant, yes, but it is a massive exam trap because of the clinical execution. You absolutely cannot infuse a rejuvenated unit of blood directly into a human being.
Why? Because of the inosine.
Yes. Inosine is metabolized into uric acid in the human body. If you transfuse that entire bag of rejuvenating solution, you will precipitate massive amounts of uric acid crystals in the patient's kidneys, driving them into acute renal failure.
Oh, wow. So how do you make it safe?
The protocol requires you to add the solution, incubate the bag at 37 degrees Celsius so the red cells can absorb the nutrients and rebuild their internal engines.
Right.
And then you must aggressively wash the red cells with continuous cycles of sterile saline. You must wash away every trace of the rejuvenating chemicals from the surrounding plasma before that blood ever reaches the patient.
That is a critical safety mechanism to understand.
Yeah.
Now, let's explore what is physically happening to the blood during those 42 days. It sits in the refrigerator at 1 to 6 degrees Celsius. The industry refers to this gradual biochemical degradation as the storage lesion.
This is a fundamental concept. A bag of blood on day 2 is vastly different from a bag of blood on day 40. The biochemical environment has radically shifted.
To visualize this, I like to use an analogy. Imagine the red blood cell is a leaky boat floating in the plasma. Normally, the cell has active sodium-potassium pumps constantly bailing water. These pumps use ATP to shove potassium inside the boat and push sodium out into the water.
Okay, good analogy.
But in the cold environment of the refrigerator, the cell's metabolism slows to a crawl. The ATP reserves deplete, the pumps begin to fail.
They lose their bailing buckets.
Exactly. Consequently, the boat starts leaking. The high concentration of potassium that is supposed to be locked inside the red cell slowly leaks out into the surrounding plasma. Therefore, as storage time increases, plasma potassium goes UP.
Yes.
Conversely, the abundant sodium in the plasma leaks into the cell, so plasma sodium goes down N.
A very accurate visualization. And we also have to consider the waste products.
Right. The cells are still slowly undergoing glycolysis, consuming the dextrose and spitting out lactic acid. That acid is trapped in the plastic bag. Therefore, the pH goes down N-way. Furthermore, the slow breakdown of cellular proteins releases ammonia into the fluid, so plasma ammonia goes UP.
You're hitting all the major points. And there's one more molecule.
Oh, right, 2,3-DPG. This molecule's entire job is to force hemoglobin to release its oxygen to the surrounding tissues. During storage, 2,3-DPG levels plummet. This causes a leftward shift in the oxygen dissociation curve, meaning the transfused red cells hold onto their oxygen incredibly tightly and are less efficient at delivering it to the patient's tissues for the first 24 hours after transfusion.
Let's summarize that storage lesion rule, because it is guaranteed to be tested over time. Potassium and ammonia go UPPH, sodium and 2,3-DPG go down.
Perfect.
Let's apply this clinically. You have a premature neonate in the NICU whose kidneys are still profoundly underdeveloped. They need a transfusion. You do not go to the fridge and pull a unit of blood that is 40 days old.
Right, because of the potassium.
Exactly. That plasma is saturated with 40 days worth of leaked intracellular potassium. If you infuse that heavy potassium load into a baby whose kidneys cannot filter it, you will induce hyperkalemia and trigger a fatal cardiac arrhythmia. For neonates, we actively select fresh blood, typically less than 7 days old, to bypass the consequences of the storage lesion entirely.
The chemistry directly dictates the clinical selection. This brings us perfectly to the blood bank pantry, component preparation. In modern medicine, we very rarely transfuse a bag of whole blood. We practice component therapy.
Yes.
We take that single 450 milliliter donation, put it in a massive centrifuge, and separate it by specific gravity into its individual parts: red cells, plasma, and platelets. This allows us to treat 3 different patients with the exact specific component they are lacking without volume overloading them with things they don't need.
And the ASCP exam will relentlessly test your mastery of this pantry. You need to know the storage temperatures, the shelf lives, the quality control metrics, and the precise clinical indications for every single component.
Let's start with the foundation. Red blood cells, or packed RBCs. After we express the plasma off the top, the packed red cells are stored in the refrigerator at 1 to 6 degrees Celsius. There is a specific quality control metric you need to know. The hematocrit of a packed RBC unit must be less than 80%.
Right.
At first glance, that seems counterintuitive to me. If the goal is packed red cells, wouldn't a 95% hematocrit be better?
No, because if the hematocrit is over 80%, it indicates that we squeezed too much plasma out of the bag. Remember, the preservative solutions, the dextrose food, and the phosphate buffer are dissolved in that liquid plasma volume.
Oh, right.
If you remove too much liquid, the red cells won't have enough nutrients to survive their 42-day shelf life. They will literally starve and hemolyze in the bag.
Clinically, the benchmark is that 1 standard unit of packed RBCs should raise an adult patient's hemoglobin by 1 gram per deciliter, or raise their hematocrit by 3%. But we frequently modify these red cells before transfusion to prevent specific adverse reactions. Let's explore the biological why behind the 4 major red cell modifications.
Okay, let's do it.
First, leukocyte-reduced RBCs. We pass the blood through a specialized microfilter that catches the white blood cells. This standard dictates the final products must retain 85% of the original red cells, but have an absolute count of fewer than 5 times 10 to the 6th white blood cells remaining. Why do we care about a few million white blood cells?
2 very distinct reasons. First, as we discussed earlier, filtering out the monocytes physically removes the hiding place for the CMV virus, rendering the unit CMV safe.
Right.
Second, it prevents febrile non-hemolytic transfusion reactions. As white blood cells sit in the refrigerator and slowly die, they rupture and release inflammatory cytokines into the plasma. If you transfuse that cytokine-laden plasma into a patient, their body reacts to the inflammation with a sudden, violent spike in fever and severe chills.
Which has to be terrifying for the patient.
And the clinical team. While it is rarely fatal, it perfectly mimics the onset of a deadly acute hemolytic reaction. The clinical team has to stop the transfusion and launch a massive, time-consuming investigation. Filtering the white cells out on day 1 prevents that cytokine buildup entirely.
Modification number 2, washed RBCs. We place the bag onto an automated instrument that washes the red cells with successive liters of sterile saline, spinning and flushing until virtually every drop of the donor's plasma proteins is removed.
Yes.
The clinical indication here is very narrow, but incredibly severe. We use washed RBCs to prevent anaphylactic shock in a patient who is IgA deficient and has developed anti-IgA antibodies. Explain that one.
Well, IgA is a standard immunoglobulin, a protein found in normal human plasma and mucosal secretions. A small fraction of the population is born with a genetic mutation where they produce absolute no IgA. Because their immune system has never encountered this protein, if they are exposed to it, they recognize it as a dangerous foreign invader and build severe, potent anti-IgA antibodies.
So if that patient needs a blood transfusion and we give them a standard unit of packed RBCs,
the residual 20 or 30 milliliters of normal donor plasma in that bag contains donor IgA. The moment it hits the patient's bloodstream, their anti-IgA antibodies attack it, triggering massive systemic histamine release. The patient's airway swells shut and their blood pressure crashes into immediate anaphylactic shock.
so by aggressively washing the red cells with saline, we strip away the donor IgA, making the unit safe.
Yes, but washing the cells introduces a massive logistical nightmare.
The open system trap.
Exactly. The moment you spike that blood bag to hook it up to the saline washing machine, you have created an open system. You have broken the hermetic, sterile seal of the original bag, exposing the contents to the potential of room air and environmental bacteria.
And because that bacterial risk, the expiration date just free falls, right? A bag of blood that was good for 42 days now expires in exactly 24 hours, and it must be meticulously maintained at 1 to 6 degrees Celsius to suppress any potential bacterial growth until it is transfused.
The 24-hour expiration rule for an open system at 1 to 6 degrees is a cornerstone blood bank regulation. You have to know it.
Modification number 3, irradiated RBCs. We take the bag of blood, place it inside a specialized irradiator, and blast it with a minimum of 25 gray or 2500 centigrade of gamma irradiation. The purpose is to physically cross-link and damage the DNA inside the donor's T lymphocytes. We are essentially sterilizing the white blood cells so they cannot undergo cellular division.
This is done to prevent transfusion-associated graft versus host disease, or TAGVHD. This is one of the most horrific complications in all of transfusion medicine.
Walk us through what happens.
If you give normal, unirradiated blood to a patient with a severely crippled immune system, like a bone marrow transplant recipient, or a fetus receiving blood through the umbilical cord, the patient's immune system is too weak to recognize and destroy the donor's white blood cells.
So the donor's white blood cells just hang around.
Worse, those donor T cells realize they are in a foreign environment. They engraft in the patient's bone marrow, multiply, and begin aggressively attacking the patient's skin, liver, and GI tract. The graft attacks the host. The mortality rate is staggering.
Oh, wow. So by irradiating the blood, we scramble the T cells' DNA. They can still circulate, but they cannot divide and mount an attack.
Precisely.
But the exam trap here is the expiration date. Gamma irradiation physically damages the red blood cell membrane, exacerbating the storage lesion and causing potassium to leak out much faster. Therefore, an irradiated unit expires 28 days from the date of irradiation or on its original outdate, whichever comes first.
Exactly. You are trading shelf life for immunological safety.
The final red cell modification is frozen or deglycerolized RBCs. If we identify a donor with a phenomenally rare blood phenotype like the Bombay phenotype, we cannot let that blood expire in 42 days. We need to stockpile it for years.
Right.
We can freeze red cells at minus 65 degrees Celsius, and they will be viable for 10 years. But you can't just toss a bag of liquid blood into a deep freezer. The water inside the cells would freeze into jagged ice crystals, physically shredding the cellular membranes to pieces.
It would look like a bag of red Kool-Aid slush. We prevent that by infusing the cells with a cryoprotectant, specifically a high concentration of glycerol. Glycerol permeates the cell membrane, displacing the water and binding to the internal structures via hydrogen bonds, completely preventing the formation of ice crystals during the freezing process.
But glycerol, much like the inosine we discussed earlier, is toxic to the human body in massive doses, right? Furthermore, it creates massive osmotic pressure. If you just thawed the blood and transfused it, the sudden influx of plasma water rushing into the glycerol-heavy cells would cause them to swell and burst in the patient's veins.
It would cause massive hemolysis. When the hospital requests that rare unit, we thaw it at 37 degrees and then run it through a complex automated deglycerolization machine. It uses descending concentrations of saline to slowly draw the glycerol out of the cells without causing osmotic lysis, washing them clean.
And because that deglycerylation process utilizes an open system, once that 10-year-old unit is thawed and washed, it expires in exactly 24 hours.
You've got the 24-hour rule down perfectly.
That covers the red cells. Now let's explore the liquid gold, the plasma components. We have two primary products here, FFP and cryo. Let's differentiate them biologically and clinically. FFP stands for fresh frozen plasma. After the initial whole blood centrifugation, we express the golden plasma into an attached satellite bag and freeze it solid within 8 hours of collection. It is stored at minus 18 degrees Celsius for 1 year, or we can deep freeze it at minus 65 for 7 years.
The clinical value of FFP is that it contains every single normal coagulation factor in its physiological concentration, including the highly labile factors V and 8. We utilize FFP for patients suffering from broad, multiple coagulation deficiencies. For example, a patient in severe liver failure cannot synthesize their own clotting factors, or a patient suffering from DIC, disseminated intravascular coagulation, has systemically consumed all their factors.
So when the trauma bay calls for FFP, we pull it from the freezer and thaw it gently in a water bath between 30 and 37 degrees Celsius. Once fully thawed, it must be stored in the refrigerator at 1 to 6 degrees, and let me guess, it expires in 24 hours.
Yes, 24 hours. Because the labile factors degrade quickly at refrigerator temps.
Okay, the other plasma product is cryoprecipitated AHF, universally just called cryo. The manufacturing process for cryo is essentially controlled temperature manipulation. You take a frozen bag of FFP, and instead of thawing it in a warm water bath, you put it in the refrigerator at 1 to 6 degrees Celsius to thaw very slowly. As it thaws in the cold, the proteins behave differently. A white, sludgy, insoluble precipitate forms and settles at the bottom of the bag. We place the bag in a plasma press and squeeze all the remaining liquid plasma out. That concentrated white sludge left behind is the cryo. We immediately refreeze it.
And that sludge is a highly concentrated powerhouse of specific clotting proteins. By FDA standards, a single small unit of cryo must contain at least 150 milligrams of fibrinogen and at least 80 international units of factor VIII. It also contains concentrated von Willebrand factor and factor 13.
Let's test this knowledge with a clinical scenario from the text. You have an ICU patient suffering from severe DIC. Their laboratory results show their fibrinogen levels have critically crashed. They are bleeding from their 5E sites. As the blood bank scientist, the physician asks you for a recommendation. Do you dispense FFP or cryo?
It's a great question. FFP contains fibrinogen, so structurally it seems like a valid option. But you have to think about the physical volume of fluid. The concentration of fibrinogen in FFP is normal. To deliver enough total milligrams of fibrinogen via FFP to correct a severe deficiency, you would have to transfuse liters and liters of plasma.
You'd flood them.
You would push the patient into severe transfusion-associated circulatory overload.
Yeah.
You would drown their heart and lungs before you ever fix their clotting deficit. Cryo is the targeted answer. It is a concentrated shot. You deliver a massive dose of fibrinogen in a tiny volume of liquid, usually only 10 to 15 milliliters per bag.
That clinical distinction is absolutely crucial for the exam. Now, here is a major logistical trap regarding cryo. Because the volume in a single bag is so tiny, an adult therapeutic dose requires pooling. The laboratory scientist thaws 10 individual bags of cryo, physically cuts the tubing, and pools them all together into one large bag for the nurse to hang.
Yes.
By cutting the tubing to pool them, you have created an open system. What is the expiration time of that pooled cryo?
The instinct for most students is to shout 24 hours, because that is the hardwired open system rule for washed red cells and thawed FFP. But you have to account for the storage temperature. Red cells and FFP are stored in the refrigerator at 1 to 6 degrees, which actively suppresses bacterial growth, buying you 24 hours.
The cryo is different.
Very different. Cryo must be stored at room temperature once thawed. If you put it back in the refrigerator, the cold temperature will cause the fibrinogen to precipitate back out of solution into a solid mass right in the bag.
So because pooled cryo is sitting in an open system at room temperature, which is a perfect incubator for bacterial proliferation, it expires in exactly 4 hours. That 4-hour mark is heavily tested.
The 4 hours. Do not forget it.
Finally, the last major component, platelets. We have referenced them throughout, but let's formalize their parameters. Platelets are stored at room temperature, 20 to 24 degrees Celsius, and they must undergo continuous agitation. They sit on a mechanical agitator that gently rocks them back and forth 24 hours a day.
And the biology here is respiration. Platelets are highly metabolically active cells. They constantly consume oxygen and produce lactic acid and carbon dioxide. The plastic blood bags are engineered to be highly gas permeable. The constant rocking motion ensures continuous fluid movement against the plastic, facilitating gas exchange with the room air allowing oxygen to diffuse in and carbon dioxide to diffuse out.
So if the agitator breaks and the platelets sit still?
They will literally suffocate. The lactic acid will build up locally, the pH will plummet below the critical threshold of 6.2, and the platelets will irreversibly change their physical shape, rendering them completely useless for clotting.
Wow. And because they must be stored at room temperature, the risk of bacterial contamination from a microscopic skin plug during donation is exceptionally high. Therefore, the strict shelf life for platelets is only 5 days. You also must memorize the minimum yields. A single whole blood-derived platelet unit must contain at least 5.5 times 10 to the 10th platelets. And a apheresis unit must contain at least 3.0 times 10 to the 11th platelets.
And here is the physical administration trap that you need to know. Do not transfuse platelets through a microaggregate blood filter. Platelets are inherently sticky. Their entire biological purpose is to aggregate and form a plug when they encounter resistance or debris.
Right.
If you run them through a tiny 40-micron microfilter designed to catch cellular debris, all your platelets will activate and stick to the filter mesh. The patient will receive a bag of very expensive, entirely useless plasma. Always use standard 170-micron blood tubing filters for platelets.
We have safely collected the blood, tested it, preserved it with chemistry, and separated it into the perfect component. We are rounding the final corner into the immunohematology testing bench.
The final hurdle.
We have a patient who needs blood. We must ensure that when we infuse that unit, the patient's immune system isn't going to recognize it as a foreign invader and rip it to shreds. We need to compare the two foundational pillars of this testing, the D and the IAT.
DT stands for direct antiglobulin test, and IAT stands for indirect antiglobulin test. The fundamental mechanisms of these tests trip up students constantly.
So to make this intuitive, let's use a criminal justice analogy. Let's start with the DATE. The concept behind the DATE is that it detects in vivo sensitization, meaning it looks for an immune reaction that has already happened inside the living patient. It is like walking onto a crime scene and finding a body with the murder weapon already sticking out of it. We are asking, are there antibodies physically attached to the red blood cells currently circulating inside the patient's veins?
Exactly. We are not trying to force a reaction in the test tube. We are simply gathering evidence of a reaction that is already underway. We use the DAT to investigate hemolytic disease of the fetus and newborn, where the mother's antibodies have already crossed the placenta and are attacking the baby's cells. We use it to investigate autoimmune hemolytic anemia or to diagnose a delayed transfusion reaction.
Okay, so how do we run it?
We draw a sample of the patient's blood, preferably in an EDTA tube, because EDTA chelates calcium, which paralyzes the complement cascade and ensures we don't accidentally trigger in vitro complement attachment while the blood sits in the tube.
And the beauty of the D is that there is absolutely no incubation required, right? The incubation already happened inside the patient's body.
Exactly. We take the patient's red cells, wash them thoroughly with saline to wash away any free-floating, innocent bystander antibodies in the plasma, and then we add our chemical detective, polyspecific antihuman globulin, or AHG.
Polyspecific AHG. Explain how that works.
This requires understanding zeta potential. Red blood cells possess a negative electrical charge, meaning they naturally repel each other. Human IgG antibodies are physically too small to bridge the gap between two repelling red cells. So even if the red cells are coated in IgG, they won't visibly clump together in the tube.
You won't see anything.
Right. The AHG region is an anti-antibody. It is an antibody designed specifically to grab onto the Fc portion of human IgG or to grab onto human complement protein C3. The AHG is physically large enough to bridge the gap. If the patient's cells are coated with immune proteins, the AHG grabs them, links the adjacent red cells together, and causes a massive visible lattice formation agglutination in the test tube.
So if that initial D tube turns positive, we know a crime has been committed, the cells are being attacked. But we don't know the exact weapon. Was it an IgG antibody or was it the complement cascade?
Yes.
So we run a follow-up test using monospecific sera. We run one tube with just anti-IgG and another tube with just anti-C3. This differential identifies exactly what kind of protein is coating the patient's cells.
That is the direct antiglobulin test. Now, contrast that entirely with the IAT, the indirect antiglobulin test.
The IAT detects in vitro sensitization. This is not a crime scene. This is an interrogation room. We take a suspect and a weapon, lock them in a room together, and see if they will strike. We use the IAT for antibody screens and cross-matches. We are asking a predictive question. If we mix the patient's plasma with these specific red cells, will their antibodies attack them? We are trying to force the reaction to happen in the safety of a glass tube before we ever risk letting it happen in the patient's body.
Perfectly said. For the IAT, we take the patient's serum or plasma, which contains their free-floating unattached antibodies, and we mix it with commercially prepared reagent red blood cells that possess a known, highly mapped antigen profile. Because the reaction hasn't happened yet, we cannot just add AHG and look for clumping. We must incubate the tube.
We incubate the mixture, typically at 37 degrees Celsius, which mimics human body temperature. This incubation phase provides the necessary time and thermal energy for the patient's IgG antibodies to physically locate their target antigens on the reagent red cells and attach to them.
Right.
After the incubation, we watch the cells to remove any unattached plasma proteins. Only then do we add the anti-human globulin region. If we see agglutination now, it means an antibody from the patient's plasma successfully hunted down a target on the red cell and attached to it during the incubation phase.
And this is the exact mechanism driving the antibody screen. We mix the patient's plasma with 2 or 3 very specific Group O reagent red cells. If the IAT is positive, it signals that the patient harbors a clinically significant unexpected antibody.
And that triggers the final, most logically rigorous part of immunohematology: antibody identification. We must deduce exactly which specific antibody the patient possesses so we can hunt down donor blood that completely lacks that target antigen.
To do this, we run an antibody panel. We test the patient's plasma against an array of 10 or 11 different reagent red cells, each with a unique, mapped-out matrix of antigens. We observe which specific cells react and which ones don't, and we look for the pattern.
But the critical rule here is statistical certainty. We cannot just guess based on 1 or 2 reactions. The standard demands we achieve a 95% confidence level, a p-value of 0.05, that our identification is not a random coincidence.
This is universally known as the rule of 3. To conclusively prove the identity of an antibody, you must observe positive reactions with at least 3 distinct cells that possess the target antigen, and you must observe negative reactions with at least 3 distinct cells that lack the target antigen. 3 positive, 3 negative. That is the minimum mathematical threshold to rule out statistical coincidences.
And there is a massive exam strategy regarding the rule-out process. When you are looking at that matrix, you have to cross out or rule out the antibodies that are definitely not causing the reaction. To do this safely without killing the patient, you must understand the concept of dosage, and you must prefer homozygous cells. Let's break down the biology of a homozygous cell.
Please do.
The genes are inherited in pairs. Let's look at the kid blood group system, which features the JKA and JKB antigens. If a reagent red cell is homozygous for JKA, it means the donor inherited the JK gene from both their mother and their father. That red cell's membrane is going to be absolutely packed with a double dose of JKA antigens.
Exactly.
If the cell is heterozygous, meaning the donor inherited 1 JKA gene and 1 JKB gene, the physical real estate on the membrane is split. The cell only possesses half the total amount of JK antigens.
This physical difference in antigen density dictates how the test tube reacts. Antibodies in the KID, Duffy, RH, and MNS's systems frequently demonstrate dosage. This means they react powerfully with homozygous cells because there are thousands of targets to hit, but they react very weakly or completely negatively with heterozygous cells.
So if a patient has a weak, waning anti-JK antibody circulating in their plasma and you test it against a heterozygous cell, the antibody might not find enough antigens to form a visible lattice. The tube will look perfectly negative.
Right, and if you use that false negative reaction to cross anti-JK off your suspect list, you will mistakenly conclude the patient does not have the antibody. You will then safely cross-match JKI positive blood, transfuse it into the patient, and trigger a massive delayed hemolytic transfusion reaction as their immune system rapidly mounts an anamnestic response.
That is terrifying. So the absolute rule for the exam: when you are trying to cross an antibody off your list, you must find a reagent cell that is homozygous positive for that specific antigen, but yielded a completely negative reaction in the test tube. That double dose of antigen guarantees that if the antibody was present, it would have reacted. It is the only immunologically safe way to rule it out.
The exam writers will intentionally give you panels where ruling out on a heterozygous cell leads to the wrong answer. Trust the homozygous rule.
We have covered an immense amount of biological territory today. Let's trace the logic flow one last time. We started with the strict physiological mathematics of donor selection, understanding how baroreceptors and megakaryocyte kinetics dictate the safety of the donor and the timeline of deferrals. We explored the epidemiological assumptions behind hepatitis age cutoffs and the horrifying resilience of prions.
We walked step by step through the citrate toxicity math of autologous collections. We explored the molecular revolution of NAT testing, utilizing PCR to bypass the immune system's window period.
We dove deep into the biochemical survival of the red cell, tracking how adenine generates ATP, how lactic acid plummets the pH, and how failing sodium-potassium pumps dictate the clinical dangers of the storage lesion. We defined the blood bank pantry, explaining the cytokine mechanisms behind leukoreduction, the anaphylactic risk of IgA, the devastating T-cell engraftment of TA-GVHD, and the volume overload logic of choosing cryo over FFP.
And finally, we broke down the immunological crime scenes and interrogation rooms of the DATE and the IET, ending with the statistical certainty and dosage mechanics of antibody identification. If you can track this underlying biology, the exam stops being a list of disconnected roles.
It becomes a predictable system. When you understand the mechanism, you can deduce the answer to a clinical scenario you've never even seen before.
But before we end this deep dive, I want to leave you with a final concept to mull over. We talked extensively about how NAT testing revolutionized the industry, utilizing molecular amplification to shrink the window period for HIV and hepatitis C down to just a handful of days. But consider the absolute biological limit of diagnostic testing. Let's say, theoretically, we engineer an assay so sensitive it can detect a single viral RNA copy the literal second a donor is infected. Even with that perfect test, would we ever reach a truly zero-risk blood supply?
The terrifying reality is that we only test for the pathogens we already know about.
Precisely. What happens when a novel emerging pathogen jumps into the human population, like Zika did a few years ago, or an entirely unknown agent we haven't even named yet? It will circulate freely in the blood supply, hiding in a window period not of testing limits, but of profound scientific ignorance. We will transmit it until we recognize the epidemiological pattern and invent a new test.
Wow.
Until the day we can synthesize perfect, fully functional artificial red cells and platelets in a sterile, controlled factory, the safety of the blood supply will always be a high-stakes, ongoing arms race against an evolving biological world.
That is a chilling but incredibly profound perspective. It really highlights exactly why the work you are training to do on that bench is so vital. Every screening question you review, every cross-match tube you incubate, and every reaction you interpret is an active defense line in that arms race.
Keep pushing through your ASCP preparation. Trust your understanding of the underlying biology, take your time dissecting the questions, and you're going to be a phenomenal medical laboratory scientist.
Thank you for joining us on this deep dive.